Good morning, everybody. And I just have to say, I absolutely love Courtney, Gary, Allen. And thank you, Katie and Allen, for sharing your story earlier. And it's important for me to identify myself too when I come to events like this and in rooms like this. So I am Ryan Hampton. I am an author, I'm an advocate. I'm the founder and executive director of an organization called Mobilized Recovery, which I'm gonna share about in a few moments. And I'm also a person in long-term recovery, which means for me, I haven't felt it necessary to have a drink or a drug or a mood or mind-altering substance since February 2nd, 2015. I just celebrated 10 years, which is wild. And it is, there's a lot of ground and stories and just things I want to say over the course of our time here. So I'm going to be moving fairly quickly through subjects, so bear with me. But I want to say at the top, it's a profound honor to be here in Augusta. And I do want to extend my deepest gratitude to Governor Mills for her leadership and for convening this important summit once again this year. The governor's work and the work of every single person in her administration, especially Gordon, alongside every single person in this room, the advocates, the frontline organizations, the treatment workers, the treatment counselors, law enforcement officers, policymakers. It's nothing short of life-saving. Now, the recent data indicating a decline in overdose deaths in Maine is a testament to your collective commitment and the hard work unfolding across this state. It shows that with dedication and with the right strategies, progress is possible. It is a beacon, I believe, in a national landscape that often feels overwhelming for most of us. And I want to acknowledge right at the top of my talk this morning that this is an incredibly challenging time for this movement and for the communities that we serve. Many of us are feeling the immense strain, the pain, the agony, and the uncertainty caused by catastrophic funding cuts and a deepening ambiguity coming from the federal government regarding the future of addiction and mental health support. It can feel disheartening, like the ground is shifting beneath our feet just as we've begun to make hard-won progress. But let me be unequivocally clear. Now is not the time to give up. Now is not the time to retreat or to allow frustration to turn to despair. In fact, this is precisely the moment that calls for us to dig deeper, to come together with even greater strength and unity than ever before. This is the time for us to fight like hell for the progress that we have made, to protect the life-saving services that we have built, and to continue to forge a better, more compassionate, and more effective system for everyone impacted by this crisis. Despite the headwinds, our collective resolve, our shared experience, and our unwavering commitment to human dignity must be the force that propels us forward. So my journey here today isn't really just as an author or an advocate, it's as a human being who navigated the darkest depths of opioid addiction and thankfully and gratefully found my way into long-term recovery. For over a decade, addiction had a vice grip on my life. I went from a promising young staffer at the age of 19 in the White House, full of ideals, to someone who was homeless, who was couch surfing, who was wrestling with shame and eventually injecting heroin just to feel normal and just to stop the sickness. I remember hitting what some folks will call rock bottom, which for me was a place of utter dissolution. I was broken, and I was on the verge of losing everything, including my life. And in that moment of profound crisis, when I finally became willing to ask for help, there was one program that literally saved me, and it is called Medicaid. Let me be very clear. I would not be here today without Medicaid. It was Medicaid that paid for the treatment that put me on the path to recovery. It was Medicaid that gave me access to the medical care and the support that I desperately needed when I had absolutely nothing else. For me and for millions of Americans struggling with addiction, Medicaid is not just a healthcare program, it is our lifeline. It is the difference between a chance at life and the near certainty of death or continued suffering. We hear a lot about cutting Medicaid these days, about it being a drain on resources. But I am living proof that Medicaid is an investment in human potential, an investment in families, an investment in communities. It is not a handout. It is a hand up. And when we talk about seriously responding to the overdose crisis, when we talk about building a system that truly supports recovery, we have got to talk about protecting, expanding, and fighting for Medicaid at all costs. To cut it, to weaken it, is to pull the rug out from the most vulnerable among us at the very moment they need that support the most. It is cruel, and it is a direct assault on our efforts to save lives. I remember the desperation of trying to find a treatment bed, the countless calls, the waiting lists that felt like a death sentence. I remember the gnawing reality that my lack of stable housing, the economic despair, the isolation, these weren't just side effects of my addiction. They were part of what actually fueled it and made escape for me feel impossible. Medicaid helped me break that cycle. I share this not for sympathy, but more for context and with fierce urgency for each of you. Because when we talk about the addiction crisis, when we talk about the overdose crisis, when we talk about fentanyl, what we are talking about is human lives. We are talking about families that have been shattered. We are talking about a healthcare and a societal system that has too often failed those in greatest need. My experience has taught me that recovery is possible, but it also ignited a fire within me to fight for a system that doesn't just treat the symptoms, but also addresses the roots, a system that doesn't leave people behind, a system that doesn't kick people when they're down. And that fire led me, along with dedicated colleagues like Courtney, to start something called Mobilize Recovery. Now, Mobilize Recovery is an initiative that trains and supports new leaders in the recovery movement from all across the United States. We believe in the power of lived experience. There is no substitute for it, in my opinion, and in equipping individuals with the tools to advocate for change in their own communities. Change that encompasses not just treatment, but also addresses the social determinants of health that so profoundly impact a person's ability to thrive. And I'm gonna share a little bit more later on how you can get involved. And that brings me to why I'm here today, here this morning, to discuss the current landscape and the challenges that have become so starkly clear in recent years, challenges that I've explored deeply in my work. Now, when we hear the word fentanyl, it often evokes certain feelings, right? It'll evoke immediate fear for some of you. And frankly, it invokes a lot of misunderstanding. A story which I explore in the book, Fentanyl Nation, which perfectly encapsulates this fear and misinformation, unfolded in May of 2017 one evening in a place called East Liverpool, Ohio, a Rust Belt town ravaged by economic decline and consequently a place where opioid addiction was quite common. Officer Chris Green, who was a canine patrolman with an athletic build and boyish features, was at the gym one evening when he got a call from his partner, Rob Smith. Smith had witnessed what they call a hand-to-hand, a suspected drug deal involving a dark blue Chevy Impala. Moments later, Officer Green was in his unmarked car zipping through the industrial district. The driver of the Impala, 25-year-old Justin Buckle, panicked at the sound of sirens. He decelerated, desperately grabbing small bags of white powder, trying to ditch them out the window, but instead they spilled everywhere, caking his car's gray seats and carpet, and Buckle himself in what looked like powdered sugar. Officer Green, arriving on the scene, later told a reporter the next day that, quote, "When I got to the scene, he was covered in it. I patted him down, and that was the only time I didn't wear gloves," unquote. That detail, that small, brief detail about the ungloved contact becomes critical to the narrative that would follow that day and years later. The powder, it turned out, was fentanyl. Buckle was immediately arrested and taken to the station. He was sweating profusely, not just from the stress of his impending charges, but from the brutal, rapid onset of opioid withdrawal, an agony of what many of us know as muscle cramps, nausea, and anxiety that jails, unfortunately, rarely treat with the medical seriousness that it deserves. An ambulance was called for Buckle. Then the story takes its infamous turn. The captain at the station pointed out a white smudge on Officer Green's uniform. Green, thinking nothing of it, brushed it off with his thumb. And moments later, as he recounted to numerous news outlets, he started feeling quite strange. He said, "I started talking weird. I slowly felt my body shutting down. I could hear them talking, but I couldn't respond. I was in total shock." That's a direct quote from him. And then he collapsed. The EMTs attending to Buckle were suddenly redirected to Green, who was now sprawled semi-conscious on the station's cold tile floor. He was given a dose of naloxone, rushed to East Liverpool City Hospital, and there received 3 more doses, 4 hits of Narcan in total, supposedly for brushing a tiny smudge of powder with his bare thumb. His story exploded in 2017. CBS's The Morning, the New York Times podcast, The Daily, CNN, Fox News, MSNBC, it was everywhere. The opioid crisis is not only dangerous for those addicted to the drug, but also for first responders. I can remember one anchor gravely mentioned. Another reporter compared fentanyl to anthrax as a chemical weapon. Officer Green himself fueled the fire, saying, quote, "This stuff is as dangerous as anthrax. If I mailed you this stuff, it's going to kill you quicker than anthrax." Now, the nation was gripped by this terrifying account. Some of you may remember it. There was just one problem. As emergency medicine doctor and addiction specialist, Dr. Ryan Marino, then working in nearby Pennsylvania and Ohio, immediately recognized Officer Green's story was, to put it bluntly, physiologically impossible to be true. Dr. Marino, who had treated countless opioid overdoses, knew that Green's reported symptoms and the need for 4 doses of Narcan from such minimal contact didn't align with the science of fentanyl. Fentanyl isn't absorbed through the skin in a way that could cause an overdose from incidental contact like brushing off powder from your uniform. In fact, medical professionals handle pharmaceutical-grade fentanyl regularly without such incidents every single day. Green was never even tested at the hospital to see if drugs were in his system or if this account of his story was even true. So what caused Officer Green to collapse? In Dr. Marino's assessment, he believes it was fear. It was all fear. Adding to this climate of fear, the DEA itself at the time had been issuing warnings to police departments all around the United States about the supposed dangers of touching fentanyl, creating an environment ripe for such a nocebo effect where the expectation of harm can actually trigger physical symptoms. This fear, often born from misinformation, has dire consequences, let there be no doubt. It leads to counterproductive policies. It increases stigma against people who use drugs. It distracts us from real science-based solutions we need. It also echoes historical patterns of drug scares used to justify punitive measures. Meanwhile, Justin Buckle, the 25-year-old struggling with addiction, was sentenced to 6.5 years in prison, partly for, quote, assault on a peace officer, which was dealt down to him for exposing Officer Green to fentanyl. A young man's life further derailed by a narrative that was built on fear rather than facts. So to effectively combat this crisis, we really have to understand the substance itself. Fentanyl was first synthesized in 1959 by a gentleman named Dr. Paul Janssen. That's Dr. Janssen right there. Brilliant chemist. It's a synthetic opioid, meaning it's actually made in a lab, not derived from poppy plants like morphine or heroin. This is a critical distinction because it means production does not rely on agriculture. It only requires a chemist, a lab, and some precursor chemicals. Its potency is staggering though, at least 100 times more powerful than morphine. Doses are measured in micrograms, not in milligrams. This potency actually revolutionized medicine, particularly surgery and pain management. It has a rapid onset and a short duration, which can be beneficial in controlled medical settings. However, this same potency makes illicitly manufactured fentanyl incredibly dangerous on the street. As the United Nations aptly put it, fentanyl is a good medicine and a bad drug. Two things can be true at the same time. The transition from prescription pills to heroin and now to a drug supply increasingly contaminated with or replaced by illicitly manufactured fentanyl and its analogs marks the devastating third wave of our overdose crisis. People often don't know what they're taking, how much fentanyl they're taking, which leads to overdoses with such a little amount. Now, our current fentanyl crisis, our current overdose crisis, our current addiction crisis in this country doesn't exist in a vacuum. I believe it's deeply rooted in the catastrophic failure of America's longest war, the war on drugs. Declared by President Nixon in June of 1971 as a response to what he called, quote, public enemy number one, drug abuse, unquote. This war was never just about drugs. Its origins are actually far more cynical and racially charged. President Nixon's chief domestic policy advisor, a guy named John Ehrlichman, that's Ehrlichman right there, later made a shocking confession to journalist Dan Baum in 2016 during an interview. He said, and this is a direct quote, "You want to know what this was really all about? The Nixon campaign in 1968 and the Nixon White House after that had two enemies, the anti-war left and black people. You understand what I'm saying? We knew we couldn't make it illegal to be either against the war or black, but by getting the public to associate the hippies with marijuana and the blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did," unquote. This punitive, fear-based approach has never worked to reduce drug use or supply. Instead, it has fueled mass incarceration, exacerbated racial disparities, and created a cycle of harm. The crack cocaine epidemic of the 80s and 90s is a stark example. The response was not public health, it was militarized policing, disproportionately impacting black communities, leading to draconian laws like the 100-to-1 sentencing disparity between crack and powder cocaine. This despite the fact that both are the same drug. Families and communities were decimated, not by the drug alone, but by the state's punitive response that chose punishment over treatment and retribution over repair. And now as we face fentanyl and the fentanyl crisis, we see many frightening parallels to those times. We see the same fear-mongering, the same calls for harsher penalties, the same attempts to scapegoat and to criminalize. There's a terrifying push for policies that echo the same failed strategies of the past, strategies that I believe will inevitably lead to the same devastating outcomes, particularly for marginalized communities. We cannot afford to repeat these mistakes. If we only focus on interdiction, if we only focus on punishment, we are ignoring the lessons of history and we are condemning another generation. And speaking of echoes of failed past strategies, I feel it's important when we talk about the fentanyl crisis, if we're gonna be honest here, we've got to address the dominant, and what I believe and what the data shows is a dangerously misleading narrative surrounding fentanyl and our southern border. We are constantly told that the border is the primary source of fentanyl and that it's an invasion of drugs being smuggled by asylum seekers and migrants. This narrative fuels calls for more walls, more militarization, and more division. But let's take a look at the facts. What do the facts say? The data, which of much I detail in the book Fentanyl Nation, tells a very different story. According to our own federal government and the Drug Enforcement Administration and the United States Customs and Border Protection Agency themselves, the overwhelming majority of illicit fentanyl is actually seized at legal ports of entry, not in remote desert areas where migrants might cross. We're talking about official border crossings in cars, in trucks, and by pedestrians. Furthermore, the primary traffickers of fentanyl are not, by and large, asylum seekers or undocumented immigrants. Overwhelmingly, they are United States citizens. Data from our federal government, from the United States Sentencing Commission, has consistently shown that US citizens account for the vast majority, upwards of 80 to 90% of convicted fentanyl traffickers. This is fentanyl largely being moved by Americans for American consumption through established legal channels. So you might ask yourself the question, why the relentless focus on asylum seekers and building more walls? I'll tell you why. It's a political distraction. It's a convenient scapegoat that allows politicians to avoid addressing the complex realities of this crisis, the demand for drugs within our own country, the failures of our own healthcare system, and the deep-seated social issues that drive drug use in the first place. It is easier to point fingers at a vulnerable group and a physical border than it is to implement comprehensive public health solutions. This misdirection is incredibly harmful. It diverts billions of dollars in resources towards ineffective and often cruel enforcement measures, money that could be invested in treatment, prevention, harm reduction, and addressing the social determinants of health. It fuels xenophobia and anti-immigrant sentiment, further harming hardworking, law-abiding members of our communities. It undermines our ability to engage in meaningful international cooperation to address the global nature of synthetic drug production. And most tragically, it does little to nothing to actually stop the flow of fentanyl into this country and save American lives. It is, in essence, a modern iteration of the same fear-based, scapegoating tactics that have defined the failed war on drugs for decades. As people in recovery, as advocates, as folks on the front lines, we have got to demand policies that are based on facts and not emotions and fear. One of the most troubling trends and stories that I hear as I travel the country that arise from the fentanyl crisis, an echo of what I believe are the harshest impulses of the crack era, is the aggressive use of what's called drug-induced homicide laws. The premise seems quite straightforward. If you provide drugs that lead to someone's death, you should be charged with murder. It's an understandable emotional response, but is it really effective justice? Let's consider the story of Emma Semler, who was a young woman from Pennsylvania, whose experience really highlights the devastating impact of these laws. Emma and her friend, Jenny Rose Wursler, met in rehab. They both struggled with heroin addiction. On Jenny Rose's 20th birthday, though newly in recovery, she had an urge to use. She messaged her friend Emma on Facebook, asked her to get heroin for them, and for Emma's sister to celebrate her birthday. They met, they divided the bag, and they went to a KFC bathroom to get high. Jenny Rose was given an extra dose for her birthday, and she overdosed almost immediately, and she collapsed. Emma had just turned 18 herself, and her sister panicked. They grabbed the remaining heroin and syringe, and they ran, leaving Jenny Rose behind. A KFC employee later found Jenny Rose, but it was too late. She couldn't be revived. Now, you have to also remember, in Pennsylvania at the time this happened, this was before there was a Good Samaritan law. But what happened to Emma? She wasn't seen as a grieving, terrified friend who was also struggling with heroin addiction. The law saw her as a criminal because Jenny had messaged her to get the drugs. Emma was designated a drug dealer because she loaned Jenny cash for the drugs. She was deemed responsible for their purity because she paid for the baggie and provided a syringe. She was charged with intent to distribute. Because they used near a school in the KFC bathroom, her sentence was increased. And because she ran and Jenny Rose died, Emma was slammed with a federal drug-induced homicide charge, facing a 21-year mandatory minimum sentence. The prosecution during the trial framed her actions as cold-blooded and calculated, not the actions of a scared teenager in a moment of absolute panic. Think about the chilling effect of such laws. Instead of encouraging someone to call 911 and seek help, they actually incentivize fleeing the scene to avoid a murder charge. This makes no sense. It completely and directly undermines our Good Samaritan laws that are designated to save lives. Emma's life was shattered. After an appeal, her conviction was actually overturned, but she eventually pled guilty to lesser charges, still facing 10 years in prison. So let me ask this question. Was this justice for Jenny Rose? Or was it, as I call it, something called sadistic arithmetic, designed to compound suffering? These laws, as a good friend of mine, Sheriff Carl Leonard, who's the sheriff of Chesterfield County Jail, sheriff of Chesterfield County in Virginia, a Republican sheriff, says they fail to act as a deterrent for helping those deep in addiction. Carl says they punish individuals who are often low-level users themselves, doing little to disrupt the larger drug supply while devastating more families and more individuals. This is precisely the kind of policy that expands the net of criminalization without addressing any root causes. Now, behind every statistic, every policy debate, we know are human lives. Families like my friends, the Carters, Gary and Tracy Carter, who lost their son, Bryant. Bryant's life was a series of health challenges from his birth. His parents recall his early surgeries on his knees, exposing him to painkillers at a very young age. Later, a severe case of psoriasis led to more medications, including chemotherapy drugs. His parents believed this early and prolonged exposure, combined with the pain and low self-esteem from his condition, led him to self-medicate with his grandparents' Oxycontin. They kept that locked away, but Bryant found a way to access it. He eventually transitioned to heroin in college when prescription pills became harder to obtain. He came to his parents wanting help. He was doing well on Suboxone. He had met his fiancée and he was excited about their baby to come and about becoming a father. Then, an emergency appendectomy. Bryant pleaded with the doctors before surgery, "Do not give me fentanyl." He told them that he was a person with addiction and he couldn't have anything. His parents advocated for him, but the doctor said it was absolutely necessary, and he was given that after the surgery. Now, his parents believe that it was the fentanyl that pushed the Suboxone off his opioid receptors and may have led to a recurrence of his chaotic use. The week before they were to find out the sex of their new baby, Bryant accidentally overdosed on illicit fentanyl. His mom, Tracy, found him by his bed with his head on his Bible. His hands were clasped and a needle was still in his arm. She did everything she was trained to do. She administered Narcan. She called 911, but it was too late. The Carter story is one of immense love and profound preventable loss, and a healthcare system that at critical junctures failed Bryant. Or we can consider the story of Tierra Renee Brown Lewis. Some of you may know her mom, T. Scott, who's a great advocate nationally with our work. Tierra was a vibrant 28-year-old Black woman living with sickle cell anemia. Her life was a constant battle with pain managed by a staggering 19 prescribed medications, including Oxycontin, Dilaudid, morphine, and Percocet. Tierra had expressed concerns to her mom, Tiffany Scott, that the meds were only putting her to sleep, that her doctors kept refilling them despite her worries and looking for alternative treatments. And one day, in the midst of COVID, she was turned away from the emergency room because her pain crisis didn't present as COVID-19. That afternoon, Tierra died alone in her bedroom, surrounded by pill bottles, an unopened box of naloxone on her dresser. When the EMTs arrived, their focus immediately shifted from a young woman with a chronic, painful illness to the pill bottles, and their demeanor changed as they labeled her, quote unquote, obviously drug dependent. Her mother had to explain over her child's dead body that Tierra was a lifelong pain patient and not a drug addict. Tierra's story is a heartbreaking intersection of chronic illness, the overdose crisis, and the profound racial disparities and biases that exist within our healthcare system, where the pain of Black patients is too often dismissed or misattributed. These are not isolated incidents. They are the daily realities that we face, the kind of heartbreaking accounts that underscore this human toll. They speak to systemic failures, to a crisis of compassion as much as a crisis of substances. They also speak to the profound impact of social determinants, the conditions in which people are born, grow, live, work, and age, which can create vulnerabilities long before substances are ever used. Now, we know that as we grapple with the fentanyl crisis, that it's consistently a relentless moving target. Nationally, data, and I'm using this 107 number intentionally, and you'll hear later, but nationally, data from the CDC suggested that over 107,000 lives were lost to overdose in 2023. Now, it is notable that new data released just a few weeks ago shows that number decreased nearly 27% in 2024, bringing the total to a little over 80,000. While this decrease is welcome, let me be absolutely clear. It is still catastrophically high. The presence of xylazine or tranq further complicates this landscape, making overdose reversal more difficult and causing horrific flesh wounds. The drug supply remains volatile and incredibly dangerous. It's critical that we acknowledge this ever-changing reality as we craft and implement our responses. But as we grapple with the fentanyl crisis, we cannot forget another group of individuals who are profoundly impacted by our nation's response to opioids, and that is people living with chronic pain. The narrative of the opioid crisis often, and rightly, focuses on addiction and overdose. But the policy responses, particularly the 2016 CDC guideline for prescribing opioids for chronic pain, created a devastating pendulum swing. Intended to curb the overprescribing that fueled the first wave of the crisis, these guidelines were often misapplied with rigid inflexibility. Doctors facing scrutiny and prosecution drastically reduced or forcibly tapered opioid prescriptions, even for patients who had been stable and functional on long-term opioid therapy for legitimate, debilitating pain. Clinics closed. Access to compassionate care withered. The story of my friend Ann Fuqua, who's a nurse living in Alabama with dystonia, which is an incredibly painful neurological movement disorder, is a powerful example of this. For Ann, medical fentanyl administered through patches was the magic answer that allowed her a semblance of a normal life after countless other treatments had failed. But the CDC guidelines and the subsequent crackdown made accessing her life-altering medication an agonizing quest. She described having to cross state lines, sometimes taking a Greyhound bus in her wheelchair, desperately searching for a pharmacy that would fill her legitimate prescription. She told me about the fear that every single doctor's visit would be her last and be the one where they label her a, quote, fiending junkie and cut her off. This is not an isolated story. Millions of Americans live with chronic pain. When their legitimate access to pain relief is severely restricted or denied, some in desperation are pushed towards the illicit market, a market now saturated with street fentanyl, a far more dangerous and unpredictable option than their prescribed medication. This is tragic, and it's an unintended consequence of policies that lacked nuance and compassion. And this hits particularly close to home for me. My mom, who I'm leaving tonight to go visit in Florida and spend a couple days with to help her get moved in to a physical rehab, she lives with debilitating chronic pain. She can no longer walk. The only medications that have ever given her a semblance at a quality of life that have allowed her to participate with her family at nearing 80 years old are opioids. Yet she too faces constant hurdles, stigma, and the fear of being denied the relief she desperately needs. It is a profound injustice. We cannot adopt a burn the house down approach to opioid policy. Every action, every guideline, every law must be carefully considered for its potential harm to those who are already suffering. Pain patients are not the enemy. They are often the forgotten casualties in the war on drugs left behind in our efforts to contain a crisis. Now, I want to shift to something positive, and that brings me to the remarkable work happening here in Maine. It's genuinely inspiring to see the progress that is being made. Recent reports indicate an 11% reduction in overdose fatalities in 2023, and at the same time we were seeing a peak of 107,000 nationally, and a continued downward trend in early 2024. And this is not by accident, in my opinion. This is the direct result of a concerted, collaborative effort that was led by people in this room and Governor Mills. This progress reflects the power of investing in what works, expanding access to naloxone, increasing access to treatment options like MAT, supporting harm reduction initiatives, and fostering robust recovery communities. It demonstrates that when policymakers, healthcare providers, grassroots organizations, and individuals with lived experience work together, we can turn the tide. The dedication that I see in this room is precisely what our nation needs more of. You are showing the rest of the country that a different path is possible. And I know we are running out of time, so I want to close by going to my last slide and saying that there is a path forward. There is a path forward that I prescribe in the book that I believe will lead us to less overdoses and a more vibrant recovery community. Let me get to the last slide here. Building a better drug policy, 9 pillars for holistic change. My work has led me to identify 9 core pillars that I believe will transform our approach. Number 1, and this is talking at a national landscape, free universal naloxone. This lifesaver should be accessible as an EpiPen in every public space and first aid kit. The cost to manufacture it is minimal, yet price gouging has been rampant. Real-time data. We need accurate, real-time data on overdoses, hospitalizations, and treatment engagement, much like we had for COVID-19 to inform our response effectively. Addiction treatment and support on demand. Treatment for substance use disorder must be fully integrated into mainstream healthcare, covered by insurance parity and accessible when people need it most, not after weeks or months on a waiting list. Innovate treatment and prevention strategies, including research into non-opioid pain relief and upstream prevention. We need more options, especially for co-occurring substances like opioids and stimulants. The NIH budget for research into addiction pales in comparison to its overall budget, and I believe this must change. Going beyond treatment and addressing social determinants. This is key. If we only fund treatment, we are too late. We must invest in stable housing, quality education, meaningful employment opportunities, and address systemic inequities that drive despair and vulnerability. This, in my opinion, is prevention. End homelessness, Houston style, which is also a housing first model. Housing first is healthcare. It provides the stability necessary for recovery. Reimagine public safety. Shift from punitive to health center approaches. I believe in the decriminalization of personal use and to focus law enforcement on serious crime while equipping officers to connect people with services. Urban and rural harm reduction. Robustly fund and defend tailored harm reduction services everywhere from cities to rural towns. And leave no one behind. Equity must be woven into every policy, addressing the specific needs of BIPOC, LGBTQIA+, and other marginalized communities who are disproportionately impacted by both addiction and the war on drugs. Now let me be clear, these are not radical ideas. They are evidence-based, they are compassionate, and they are achievable. However, achieving them requires unwavering advocacy, especially right now. We've seen how quickly progress can be threatened. There are significant efforts underway right now to cut funding for addiction treatment and mental health services and a rollback of consumer protections in healthcare. While some of those are currently being addressed, the fight for sustained, robust funding and supportive policies is constant. That is where every single person in this room comes in. The path forward is paved by advocacy that is broad, that is deep, and that is relentless. It is paved by raising our collective voice, by demanding that our leaders prioritize human lives and human dignity over outdated ideologies and political expediency. As I've shared many times, my own journey into advocacy was born by loss and frustration. From seeing a system that was failing the people it was meant to serve. I learned early that silence equals death, and that sharing our stories, demanding accountability, and organizing for change is not just an option, it is an imperative. We need to ensure the lessons from today, the understanding of fentanyl science, the deconstruction of its myths, the historical context of the failed war on drugs, and the embrace of human-centered, equity-focused solutions translate into tangible actions here in Maine and across the country. So here's my final call to action for you. Support the organizations on the front lines. Hold your elected officials accountable, not just for crisis response, but for root causes. Educate your communities. Challenge stigma and misinformation wherever you encounter it. Advocate for policies that expand access to care, that fully fund harm reduction, that ensure housing, that promote economic opportunity, and that treat addiction as a public health crisis that it is, not as a moral failing or a crime. The progress in Maine shows what's possible. You all know that. Let that be your fuel. Let the memory of every life lost be our resolve. We have the knowledge, we have the data, we have the science, we have the solutions on our side. And looking out at what everyone has accomplished in Maine, I know that we have the passion. I hope you all leave here not just informed, but ignited, and that you take that spirit of collaboration and determination fostered in your community and build a future where the title of my book, Fentanyl Nation, is just a chapter in history, not our daily reality that we live through every day. A future where recovery is not just possible, but where it's accessible, where it is celebrated, and where it is sustained for all in communities that are healthy, that are equitable, and that are just. Thank you all so much.